All right, hello and welcome to today's Pulmonary Fibrosis Foundation Disease Education webinar. I'm Dr. David Lederer. I'm a pulmonologist in New York and I'm a medical advisor for the foundation. Today we're going to be talking about interstitial lung disease and pulmonary fibrosis that occurs in families and a lot of discussion about how the genes that make up your DNA might influence the presence of inflammation and scarring in the lungs. And I'm joined by Dr. Christine Garcia, who is professor of medicine and a pulmonologist at UT Southwestern and is an international leader in both interstitial lung disease and the genetics underlying the disease. And before I turn it over to Christine, I do want to remind everyone that everything we talk about today is really for informational purposes only and should not be construed as medical advice or medical recommendation. You should always take the information we provide you with and bring it back to your own healthcare provider. So Christine, welcome. I'm so happy to have you here today.
Thanks, Dave. Thanks for asking me to join you.
Yeah,
it's going to be a lot of fun. I appreciate it.
It is. It absolutely is. I'm going to kind of let you go, and I'll be here, and feel free to scream out, and I'm happy to jump in.
Okay, great. Thank you very much. How's that?
Perfect. Perfect.
Okay, very good. Okay, well, I wanted to just say at the outset about the topic that we're talking about today is genetics. And this is a rapidly developing field. There's been a number of tremendous technological breakthroughs that allow us to really look and pinpoint and read the DNA sequence on a base-to-base manner. And, you know, the scope of the problem is really quite mind-boggling when you think that each one of us has 46 chromosomes. We got one pair of autosomes from dad and one pair of autosomes and sex chromosome from mom, so that makes up the total complement of 46 chromosomes. Each chromosome is quite large. In fact, the amount of DNA in all of the chromosomes encompasses 3 times 10 to the 9th bases. So that's 3,000 million bases. And the bases are A, T, C, and G. So those 4 bases basically are in a line for that amount of coverage of DNA. And when you think about how many cells are in a human being, which is estimated to be 10 trillion cells, the total collective amount of DNA, if stretched from end to end, has been estimated to be able to travel from the Earth to the Sun and back 4 times, 4 round trips. So there's really a tremendous amount of DNA that we have in our bodies. And so what we're going to focus on today really for the beginning part are those bases that are inherited from mom and dad. So that's the complement of germline DNA that's passed along from generation to generation. It's hard-coded in the chromosomes. So the genetics of pulmonary fibrosis, I like to think of as kind of as a template of variation that can affect a person's individual risk for developing disease, and it may also offer some insights into prognosis once disease occurs. So we now think of the genetics in 2 basic flavors. So genetic variants or differences in the genetic code that differ between person to person are now classified into 2 major categories. One are common variants, and so those are variants that are found in general populations. So if you randomly take 1,000 people off the street, like in this picture, you're going to see that many of them share a number of common variants. There are also rare variants. So these are variants that may be unique to one person in a population, one person maybe even in the world. These are the variants that make us unique. And these may have a larger effect size. So common variants, like I mentioned, are found in a sizable portion of the population. We now know that basically the effects of these common variants are more modest because if they had been extremely detrimental, they would have been weeded out of the population by natural selection. You always have to weigh the effects of the variants in terms of the disease that are studied, and for a disease like IPF, which is still considered a rare disease, the disease really, our estimates are that it affects between, and these are rough estimates, maybe 14 to 20 people per 100,000. For a disease of that rarity, common variants really cannot substantially inform an individual patient's risk. So what do I mean by that? I mean like if you take 10 people off the street, you might find that a common variant is found in 4 of those individuals. And so since so many of them have the common variant, it's really hard to predict, well, which of those may end up with a rare disease, which is really seen in maybe 1 out of 5,000 individuals. And so that makes risk prediction more difficult. On the other hand, rare variants, there's been an explosion in interest in rare variants because of the technological leaps afforded by whole exome sequencing and whole genome sequencing, where we can actually sequence all of the bases in a person's DNA. And it's now known that 99%, over 99% of the variants that we find are actually very rare variants. So, and these may be associated with a larger effect. For example, if there's a kindred, so IPF is a rare disease, the familial form of IPF is actually quite rare. A rare variant may actually track with segregation of disease in that individual family. And we know that's the case for a number of variants that have been found in genes linked with familial pulmonary fibrosis. So how are genetic studies done? I thought this would be a good intro, since this is our broad audience of basically what's our starting point. Our starting point for all of these studies in individuals is generally a source of blood, which then is processed. The cells in the blood then are isolated, and we use the help of these big machines to extract genomic DNA from the cells, aliquot those, quantitate them, etc., for downstream applications. Really, the machines and computers that do all the hard work, the heavy lifting of the sequencing are really amazing. And what's even more amazing is storage capacities, not only for the biospecimens and the cells, but also the data that comes out of these machines. We have just servers and servers filled with data in order to do even the most basic of analyses. So I want to break this talk into 2 parts. We're going to talk about, since the title that I was given was Familial ILD, we're going to spend the first part talking about families and how we identify genes linked to the familial form of the disease. And then second of all, I want to address the larger population of individuals with IPF or interstitial lung disease, and those are the individuals that do not have a family history. No other individual, no other first-degree or second-degree family member with pulmonary fibrosis, and how do both individuals, those without a family history and those with a family history, can help us provide insights into the genetics of this disease. And so how do we do that? So I want to use a lot of examples, and a lot of these examples come from individuals and families that I've interacted with or been referred to me. So in this first family, I don't know if you can see my pointer, but here's the proband. The proband in a pedigree is always indicated by the arrow. This gentleman, I know he's male because it's a square. So this individual was 56 when he was referred by Dr. Torres, who heads our lung transplant program at UT Southwestern. And he came with the family history. He said that his brother had died of age 41. He had a combination of pulmonary fibrosis and lung adenocarcinoma. And he also knew that his mother was similarly affected with pulmonary fibrosis and lung cancer. She died at age 54. And so this is the family history this gentleman knew about with pulmonary fibrosis. But as in most families, sometimes a little bit of digging yields more information. He knew that his aunts knew more about the family history, and he referred me to both of his aunts. And when we called them, there is actually a number of other individuals in the family who were similarly affected. This aunt knew that two of his cousins actually had been diagnosed recently with pulmonary fibrosis. And then there was a doctor in the family in this part of this upper generation who knew of individuals in two branches of the family that had very early onset clubbing of the fingernails and shortness of breath and cough. And so that led to the identification of these cases of pulmonary fibrosis and lung cancer in these two other branches of the family. So by getting a blood sample from all the individuals here who were willing to participate in the study, we were then able to then compare markers across the entire human genome to figure out which regions of the human genome were shared in common, identical across the descent, across these multiple generations. And that's a term known as genetic linkage. And we were able to narrow down from all the chromosomes into one particular region on chromosome 10. This region was quite large, but right in the middle of the region were 3 genes that were expressed solely in the lung. And these are genes that encode for surfactant proteins, which are key proteins that are secreted into the alveolar space of the lung that protect our lungs from pathogens and other insults. And so we sequenced those 3 genes, and we found that in that family, that large family I presented, there was a heterozygous change, which means that one copy had been changed to lead to a predicted change in the amino acid sequence of the gene. We found another family that had a change just a little ways down in the gene and in the same gene, and this is a gene encoding for surfactant protein A2. What we do know about this gene now is that, as I showed you, those variants, the variant that we found co-segregated with lung disease in that family. That means everyone for which we could test who had pulmonary fibrosis or lung cancer actually had the same glitch or the same change in their DNA in this one gene. We know that that gene is highly conserved across all air-breathing species. In fact, there is a conserved glycine there for all species, and so the change at that position was significant. Across the world's largest database, and so this is updated as of 2017, no one else in the general population has been found with that variant, which makes that variant extremely rare. And we know that that variant in studies done in the laboratory leads to the production of a protein that does not have normal function. In fact, it's not allowed to be secreted from the cell. And then there's now independent reports across the world that link variants in this same gene with pulmonary fibrosis, with lung cancer, and there's a new report associating it with lung cancer, with primarily lung cancer. So we do know that these variants are now linked across multiple rare families and individuals. And so this variant is likely pathogenic. It's likely what's caused the disease in so many individuals in that one family. And so that's how family studies are done. So what about the other majority of patients that don't have a family history? Is certainly, I hope, not like the one that I just showed you. Well, we can still use blood samples and DNA samples from those individuals to figure out shared genetic causes or associations with disease. And we do that by comparing different groups of samples. So we'll compare DNA samples of patients versus DNA samples from those without disease or controls. Here the statistical analysis is more complex, but we're basically trying to figure out what variants are seen more in the patients versus the controls. And so we can do this both in patients with no family history of disease. We can actually also do it in patients with a family history of disease if we take into certain statistical considerations and logistical considerations. And I'm going to mention both of those. So in the largest study that have been done across individuals with pulmonary fibrosis, It's called a GWAS study, or a genome-wide association study. This was a study that was spearheaded by David Schwartz and his colleagues that really assembled an impressive number of cases. All told, there was a discovery cohort and then a replication cohort. So there was approximately 2,500 cases of adult onset idiopathic interstitial pneumonias represented in this study. And they compared those to over 6,000 controls. Here they're looking at markers across the genome. Most of the markers are found in what's termed junk DNA, or that DNA that's not encoding for genes. And as a reminder, less than 2% of all your DNA actually codes for proteins, and the rest encodes for other things. We now know that encodes for RNA components, as well as structural important regulatory regions in the so-called junk DNA. And there's a lot of the junk DNA. We just don't know what its purpose is. And so markers across the non-coding regions, largely in the non-coding regions of the genome, were then assayed and compared in people with pulmonary fibrosis versus those without pulmonary fibrosis. And so this plots the signal across hundreds of thousands of these variants, and this is called a Manhattan plot because it kind of, Dave's from New York, it kind of looks like a bunch of different skyscrapers here, and of course the tallest skyscraper indicates the highest significant signal, and that's in the non-coding region of a gene called MUC5B. MUC5B is expressed in the lung. It's very important in protecting the lung from infections. And this SNP in the promoter of MUC5B is the most replicated SNP associated with IPF, with idiopathic interstitial pneumonias, and now with subclinical pulmonary fibrosis. So it's been replicated across multiple different studies. In genetics, we try to estimate the effects of variants, and we do that with something called an odds ratio. And here I've shown you the odds ratio for MUC5B from that paper in which I pulled the last slide, and it was estimated that the odds ratio for the risk allele was 4.5. In comparison, this other paper by Kaskar and Koltis estimated the odds ratio of smoking for IPF at 1.6. And so the genetic risk of having one of this common variant was actually quite significant. This variant has an allele frequency in the normal population of being 10%, and so it's considered a common variant. It's found, an allele frequency is a genetic term of measuring how common we find that particular variant in the population. And it doesn't necessarily mean that 10% of people will have it. In fact, a higher number of individuals have that allele with an allele frequency of 10%. And I've just done some rough calculations here. For 5,000 individuals, random individuals, 950 will actually have the risk allele, either one copy or two copies of the risk allele. And like I said, considering the disease frequency of IPF, for 5,000 individuals, approximately one will have IPF. So you see the problem with common variants. Many individuals will have the risk allele, but only one will have IPF. So many more people will have the risk allele than would be expected to develop the disease. And so while they're highly statistically significantly associated with the disease, there's limited use in informing individual risk of who's going to develop the disease. So similar comparisons can be also made now using patients with disease or controls by sequencing all the coding genes. So this is possible through a technological advance called whole exome sequencing, where we're able to sequence all the coding genes in a person's genome. And by calling all the different variants in each person, and then binning them into the different genes, we can then compare what's the burden of variance in different genes across individuals. And then we can do a number of analyses to compare variants of similar characteristics, either of frequency or those that are predicted to alter protein, etc. So we did a study here where we looked at coding variants in families, those with a family history, and we compared those to controls. And we found evidence of two novel genes associated with pulmonary fibrosis. And these pictures just show that the anticipated burden of variants would fall along the red line. But for two genes in particular, the burden of variance was higher than what would be predicted. And these two genes, PARN and RTEL, were found in those families. And here I like to use this as an illustrative example of one anomalous result that we found, or initially we thought was anomalous. All of the variants that we found in those two genes were extremely rare. So they were what was termed novel. So up until the point that we did the study, they had not been described in any of the world's population genetic databases or warehouses. And yet we found one of these rare variants in PARN in two individuals representing two different probands of families that at different times had come to UT Southwestern for evaluation. This 68-year-old woman right here, she was a patient of mine, and she told me that her father had died of the disease at age 56, and her uncle had died of the disease, and her grandfather had an ill-defined lung disease. His workup preceded the time of CT scans, and so we weren't really sure about what his lung disease really entailed. And another proband, this woman, 73-year-old, was a patient of one of my colleagues, Dr. John Fitzgerald, and Dr. Fitzgerald actually cared for her brother who died of pulmonary fibrosis, and they knew that their father had similarly had an ill-defined lung disease. And it was curious that two of the individuals that we had sequenced and put through the study had this completely novel variant. So again, although we try to take a thorough family history, and we do our best, when we found this striking result, we thought, well, maybe we don't know the full story. And actually, I contacted this woman, this 83-year-old, and she had records of the family history saved in an old Bible, so we were able to figure out who the above generations were. And then this family, there was a genealogist in this family who actually had put together all the information about the ancestors of this family, and we found that there was a shared name on both pedigrees. In fact, this one woman is the same great-grandmother of both of the probands, so we were able to link both families together. And in fact, both families actually live in Texas. They live in small villages, small cities in East Texas, about 100 miles away from each other, and they didn't know of the existence of each other. But by piecing it together and by finding these shared ancestors, we can see actually that there is co-segregation of the same rare variant in individuals with pulmonary fibrosis. And so the odds just of this happening by chance are very small, in fact about 4,000 to 1. But what's notable here, and this is something that we see a lot with the PARN variants, is that there are a number of individuals with the same rare variant here, an 82-year-old, a 77-year-old, a 62-year-old, and a 52-year-old, with no evidence of pulmonary fibrosis. So in genetics, we term this reduced penetrance, people who have the risk allele and yet do not get pulmonary fibrosis. So it kind of mirrors what we saw with the MUC5B variant, more people with the risk allele than manifest pulmonary fibrosis. So there must be other hits or other components that lead to pulmonary fibrosis. Genetics alone can't completely explain who's going to get pulmonary fibrosis. And So this slide basically summarizes a lot of the different genes and variants that have been linked with pulmonary fibrosis, and really just their classification as I've laid out. Rare variants that have larger effects but more rare, and so found in a much smaller percentage of the population with pulmonary fibrosis, and then common variants which are found more commonly in those with pulmonary fibrosis, but their effect size being more modest. And we can also group genes by pathway, and we have noticed over the last 10 years that a number of the genes for which there are variants, either rare or common, all align in the same pathway that leads to telomere shortening. And so telomeres are those areas of your chromosomes at the very end, here highlighted in this picture by the little green dots. And telomeres, we know, shorten with age, but people with mutations or pathogenic variants in these genes can lead to extreme shortening of telomeres. And that's just shown in this data slide. Here, this represents the spread of telomere lengths in blood cells from control individuals collected in Dallas, Texas. This is a spread of telomere lengths of all the spouses who have graciously provided samples as controls for patients that we collect. In comparison, these are the telomere lengths of individuals with pathogenic rare variants in either component of telomerase, either the protein component of telomerase or the RNA component of telomerase. And you can see there's a wide spectrum or spread. This represents the first percentile. So the median is about the first percentile, but there's a lot of variability using this particular assay. And we compared in one study the telomere lengths of individuals, and these are those without a family history, with various interstitial lung diagnoses. So for example, IPF versus connective tissue disease-associated interstitial lung disease. And we estimated in this study that approximately 25% of individuals had telomere lengths below the 10th percentile, certainly not as fewer numbers than those with the rare mutations in the telomerase complex, but telomere shortening being a characteristic of IPF. But the other non-IPF diagnoses also, we could see individuals with evidence of some telomere shortening as well. And telomere length, we know, basically is an independent risk factor for survival. And this is on top of what we know of in terms of prognostic effects from age, gender, and baseline pulmonary functions testing. And most recently, the paper just came out in print, I believe July 1st, in one of the pulmonary journals, of a study that was done by investigators at Duke University, spearheaded by Scott Palmer and David Goldstein, where they sequenced all the coding regions of all individuals who were referred or worked up at Duke for lung transplantation. And they found that and allowing access for the enzyme telomerase to then build up the telomere end. PARN is important for basically maturation of one of the components of telomerase. And so we see that there's a plethora of rare variants found in individuals either with a family history of pulmonary fibrosis or those without a family history. So this also strengthens the evidence for the link between these telomere-related genes and pulmonary fibrosis. And so rare variants in a number of different telomere-related genes, also in some surfactant-related genes, are linked to pulmonary fibrosis. These rare variants are found in unique individuals. There's many different terms for this from the genetic literature. These may be considered private variants, those that are private to an individual or private to their family. They're also termed ultra-rare or novel. Basically, we can assess the effect of the variants by looking at a number of different characteristics, and this is where the genetics gets a little messy in terms of how do we determine which variants are actually pathogenic. And not everyone who inherits one of these rare variants develops pulmonary fibrosis. And so, like I mentioned, there must be other hits that lead to disease. And so the interpretation of these rare variants can be complicated. Sometimes it's not, sometimes it's quite straightforward, but in other cases it can be quite complicated. For example, a family or a person with a strong family history of pulmonary fibrosis may have their genes sequenced, and they might find a variant in one of these genes that has never been found before. Our genetic terminology would call that a variant of unknown significance if it had not previously been linked to the disease itself. And sometimes people, both the doctors and the patients, are left scratching their head, what do I do with a variant of unknown significance? And this is an evolving field. I think we're going to have a lot more clarity in the years to come. But at this point, I can tell you quite honestly that sometimes the interpretation of these variants can be complicated. So telomere shortening, I like to compare it to basically an unraveling of shoelaces, with the telomere being the end of the chromosome, similar to these little plastic or metal pieces called aglets. As telomere lengths shorten, it can cause basically problems to the entire chromosome and genetics. I just want to end, because I know there's going to be other questions, but I just kind of want to broaden what does it mean about telomerase. Telomerase is a protein that's been known about for decades. In fact, it was initially discovered and characterized extensively in cancer cells. You can think of it as a fountain of youth. It's an enzyme that, by adding onto the chromosomal ends, allows cells to basically replicate without having this problem of the frayed shoelaces. And so what we've recently found is that in some rare individuals with germline mutations that have reductions in telomerase protein activity, actually they acquire a second hit or a second genetic hit that's only in somatic cells, so these are not passed on to their children, but these second hits can actually upregulate telomerase in certain cells. And so there's evidence from a genetic standpoint of a balancing mechanism of how important this is. And it's important to realize that this balance between aging or senescence is balanced by a predilection towards cancer. So this is a very important biological pathway in humans and all organisms. And so our conclusions for the talk today are that germline variants lead to an increased risk for developing pulmonary fibrosis. Genetic variants can be defined as either common or rare based on their overall frequency in normal populations. Rare variants in several different genes can lead to telomere shortening, and that pathway we now know we can find. While it was discovered initially in family-based studies, we now have more and more evidence that these variants are also found in people without a family history. The interpretation of genetic variants is complicated and requires assessment of a number of different features, which I've listed here, but it's really done on a case-by-case basis. So, this leads to a lot of different questions about genetic testing and, a future role of genetics leading to risk prediction scores. And, I can give you some brief thoughts, but maybe we'll have the opportunity for Dave and I to flesh these out. My personal opinion is that genetic testing should be used in certain situations when there's a strong family history of disease and when the person who has pulmonary fibrosis is coming and asking for the testing. Because what's hard to do is interpret the results, and it's easier to interpret the results of the genetic testing if we know other individuals in the family with pulmonary fibrosis share the same variant. And so that's my idea. And if there are maybe future roles of treatments related to genetic variants, this is an open question at this time, but certainly one that's intriguing, especially with the push towards personalized medicines and medications. You know, it may be that in the future that this will become a reality. It's not at this point, but it's certainly something that we're looking forward to see whether or not that's the case. And then finally, always people ask me about gene therapy and stem cell therapies. Again, these are things that have been proposed, but so far there is no hard data that any of these would work. And this is just a shout out of a special thanks to all the patients and especially the families who have participated in all of our family-based studies, as well as a thanks to all the collaborating physicians and scientists. And this is just a picture, as all of you know, pulmonary fibrosis and interstitial lung disease is a challenging diagnosis, and it really takes a number of individuals, physicians, nurses, staff, genetic counselors, research coordinators, pathologists, and radiologists who make up the team, the care team, and for taking care of people with pulmonary fibrosis. And so with that, I'm going to turn it back over to Dave, see what questions he has prepared for me.
Wonderful, Christine. That was really spectacular and very helpful. I think I even learned something I didn't know too. So that was great. So we have a lot of people on the line, and some people during registration had submitted some questions, and we've selected 3 questions that take this wonderful knowledge that you've shared and begin to really take it to the patient. Because I get in my own practice, and I'm sure particularly in your practice, I get very commonly asked about, number one, should my family members have genetic testing? And number two, should I be screened in some other way for interstitial lung disease if my family has, if someone in my family has ILD? So maybe what I'll do is I'll ask you, because you addressed this in families in your kind of concluding or future direction slide. You talked about, well, if there are 2 or more people in the family who have it, that's a special circumstance, and we're going to address that genetically in a particular way. But let me ask you, in the maybe more common scenario, where you have a patient in the office and their family member, their adult child or sibling says, should I have some kind of genetic testing? How do you approach that? And I guess the related question is, should the patient themselves or multiple people in the family consider genetic testing?
Sure, that's a great question. It's one that is posed quite often. So what I would say is that family history is really important, and from those 2 illustrations that I showed, you could see just really how important the family history was in actually unraveling the mysteries of both PARN and the surfactant A mutation that I presented. So family history, I think we shouldn't underestimate family history. If there is no one else in the family with pulmonary fibrosis, then that strongly speaks to the fact that the inherited variants, or that composite amount of DNA that you have inherited, there's probably not any major driver of pulmonary fibrosis, because so far all the variants that are linked to pulmonary fibrosis have been linked in the heterozygous forms. You only need 1 copy. So there's a 50% chance of passing on risk variants, and you would have received one from either parent. Now, there may be that there's not a lot of children in your family, or a lot of siblings or aunts or uncles, so maybe there's not a lot of people in your family to determine whether or not there's a family history. But for that person that comes from a very large family, and there's just no one else that's been diagnosed with pulmonary fibrosis, it's most likely that there are weaker effects or weaker genetic variants that may be driving the risk for pulmonary fibrosis. But in my opinion, there's no reason to test that person for known genetic variants. And there's two reasons. One is because we have no treatments as of this point that could be then used for particular variants. And two, there's no real reason because we cannot then provide a risk for family members. And so I have to answer a yes for both of those, a yes especially for the risk of family members before I'll send genetic testing.
And I, of course, I agree with you there, and I think there's fairly wide consensus about that in our community, but it still is obviously a very common question from patients, and appropriate question from patients and their families. So the bottom line takeaway I'm hearing from that question is there's no real reason for family members to get genetic testing in the clinical setting when there's one person in the family with the disease. And number two, in that same family, there's probably no reason in the clinical setting for the patient with PF themselves to get genetic testing, right? This is outside of 2 or more people, which is a different story. Is that accurate?
That's correct.
Yeah.
That's correct. That's my clinical practice right now.
Yeah, mine too. I really like that you mentioned you know, essentially, what can we do with that information, right? So for the patient, we're not going to change treatment because there's one genetic test result or another because we don't have that knowledge yet. And number two, for the family member, if they have a particular, even if they have the same genetic variant that their you know, mother, father, or sibling might have, there's really no way to predict what the risk of developing disease is for that family member. And I'm really happy you brought that up. That's something I emphasize. And you pointed out, you know, that, you know, like 950 out of 5,000 people have this one genetic variant that's linked to pulmonary fibrosis, and most of those people will never get the disease. So even if they tested positive, what do we do, right? So I'm glad you said that. I'm sorry if I haven't just reiterated what you said, but it's so important. I think it's something a lot of our listeners are super interested in. And the second question is slightly different. It's not necessarily genetic testing, but the question is phrased as at what age, or it could be phrased as should someone should a first-degree relative, which is a sibling or child, technically also a parent, but usually we're talking about siblings and children, should a first-degree relative of a person with IPF get screened for disease? And maybe I'll say a few words and then I'll ask you to comment as well, because this is something that I think you and I are both very interested in. So my clinical practice is that I do not recommend screening, and the word screening means someone with no symptoms and no signs of any disease and go and get tested for the disease. And good examples of screening that we do all the time are, for example, mammography to screen for breast cancer, or colonoscopy to screen for colon cancer, and even nowadays screening for diabetes and screening for high cholesterol and high blood pressure. Those are all screening because those are we do those in everyone, in healthy people of a certain age who have a certain risk factor. And there have been no studies, to my knowledge, looking at screening for family members, people with pulmonary fibrosis. So what I tell my patients' family members when they ask about this is, first we talk about, you know, could it happen to you? Well, it could. Pulmonary fibrosis can happen to anyone, and yes, maybe the risk of developing the disease is higher because you have a first-degree relative, but we have no idea how much higher. You know, it might be a small amount higher. It's something we're still trying to really learn about. All I say is go and see your primary care doctor and let them know that you have this family history, and, you know, they can listen to your lungs and ask you questions about your symptoms and your health. And if there's any signs of any lung problem, then they can do what they would always do, which might be to, you know, get some kind of breathing test, like a pulmonary function test, or even get a chest X-ray. But most people are not going to be ill or not going to be sick. And there's no, in the clinical setting, no reason to get CAT scans and all of these invasive tests in people who are well, even if you have a family member. So that's my practice in the clinical setting. So Christine, I want to kind of get your input and see what you do when that question comes up. And then maybe when we turn to the third question, we can talk more about what could happen in the research setting, and that's beginning to happen at different centers around the country. So what, in the clinical setting in your office, how do you handle that situation?
Certainly, and this is a question that I would say a lot of people ask, so it's very relevant. And also, my practice is very much mirrors what you do. So there's basically two groups. One individual who does not have a family history, and then their relatives are accompanying them on their visit, and they want to know if they should be screened. I basically tell them the same exact thing that you say, which is screening is not indicated based on the rarity of the disease and the fact that you have no family history. Then I don't recommend screening. I refer them to their primary care doctor. The second case is the person who comes in with a family history of disease. Here, I think of this as a pretty special case. We know that there are rarer cases, especially if the more affected individuals there are in the family. And, I showed some examples where there's, in both of those examples, there's almost 10 people in the family with pulmonary fibrosis. And so a lot of the family members are really dealing with some anxiety about, well, I want to know what is my risk. For those individuals, and again, maybe this is based on the fact that what I see is a very rare subset of people with pulmonary fibrosis, I actually say you could consider getting a baseline screen at age 40. But I reassure them, just like you do, that, healthy living and basically, following up with their primary care it should be the forefront. But I get for that baseline screen of a CT scan or pulmonary function testing, really for two reasons. One, and I don't recommend it for all families, but for the families where there's so many individuals who are affected in that family, yes. And two, I would do something if there was evidence of early interstitial lung disease. We would completely modify environmental exposures, smoking, wood dust, metal fumes, bird feathers, no down in the house. So for some individuals we've talked about, and we've changed jobs because of early findings, and then we follow very, very carefully. And again, I think that may just represent a skewed population of who I see, because some of the families that I follow, there are just so many people who are affected.
So that's very helpful, and I just want to clarify. So you're saying when there's two or more people in the family, you are more aggressive, and when there's one person in the family, you say go see your doctor. Am I interpreting what you said correctly?
Yes, and when it's two or more, there's also, if the two people are, who developed pulmonary fibrosis, say in their 80s, then I wouldn't probably recommend screening in family members. But if it's certainly early onset disease, of the other individuals in the family getting pulmonary fibrosis, before age 50, if there's more than two, like I mentioned in these family examples, like if we knew of 10 people, 5, 6, it's a judgment call, right? And I would say that most people don't opt to get screened, but some people do want to know if there's any early disease. And so it's kind of a gray area, I would say, in terms of who I recommend.
Yeah, I like that you use the word gray area, because that kind of helps us transition to the third question, which is about research and familial disease and genetics. And so I think one part of this question is anyone doing genetic research in ILD? And of course, you are doing it. You're kind of leading the field at UT Southwestern. And as you mentioned, David Schwartz in Colorado, and there are folks at Vanderbilt, as well as at Harvard and Brigham and Women's Hospital in Boston, who are doing this, and we're doing some of it here at Columbia as well, although maybe not to the same extent you all are doing it. So yes, many people are looking at this. And the other element related to research is about, are there ways that we should be studying early disease, as you alluded to, in the research setting in families of people where there's just one person with disease. And I'll just say that we at our center, we're beginning to do this. We have a research protocol where we do CAT scans and PFTs, et cetera, in family members, adult family members of our patients who have interstitial lung disease. And I know that there are other centers around the country that are also beginning to do this. But to be very clear, that is, in our, at least in our case, a research study and not clinical care. And I do want to make sure the audience understands the distinction, whereas clinical care is what healthcare providers give you when you come to the office or come to the hospital. And research is very different. It's where we're studying whether or not doing things like CAT scans are helpful in this patient population. So, Christine, do you want to comment or share your experience with that?
I think it's really important that we continue doing research. There's a lot of unanswered questions, like we've both alluded to. I think we're just really at the tip of the iceberg in terms of genetics of pulmonary fibrosis. There's a lot of really exciting times, I think, down the road. I'm certainly really happy to be part of the multiple, investigators across the world who are really doing this research. And so I want to emphasize, just like you did, Dave, how research studies are quite different and distinct from clinical studies. And if individuals have the opportunity to participate, I would encourage you to do so. Really, all of our understanding comes on the backs of those who have previously participated. And so we all owe all of these individuals, families, a debt of gratitude for their help.
Yeah, I 100% agree, and thanks for saying that. So I do want to wind up. This was really, really terrific. I want to remind our listeners that this was all informational, and you should not interpret anything we've said as medical advice or medical recommendation. You should discuss this information with your own healthcare provider before making any changes to your medications or seeking out any other treatments. So Christine, thank you so much. I do want to thank our supporters, our sponsors, including Boehringer Ingelheim and Genentech for supporting this webinar series, and thank you all for listening in. You'll hear more about our next webinar in the coming weeks. And Christine, most of all, thank you so much for your time and sharing your expertise about this. Thank you so much.
Okay, thank you, Dave.
All right, bye-bye.